Good afternoon, everyone. I'd like to welcome you to our August MAC meeting. We'll just give everyone a minute or two to get on the call, and as many are already doing, for those of you who are on the MAC, if you will drop your name in the chat so Sharon can keep track of everyone and know if we have a quorum.
Good afternoon, Michael. So we do have a quorum.
All right, very good. Thank you for that report. We appreciate that, Sharon. All right, prior to the meeting, Sharon did distribute copies of our last meeting in email. So if anyone has had a chance to review those and feel like there are any changes to be made, we'll open it up for any proposed changes. Okay, hearing none, then I'll entertain a motion to approve the minutes from our last meeting.
I'll move to approve.
Second.
Thanks, Colleen. All right, and then we'll just take a vote of silence. Unless anyone opposes, we'll consider the meeting minutes approved.
Sorry, I missed that. Who seconded? I know, Kim, you did the first. Who is the second?
Colleen Kenny.
Okay, thank you so much. Appreciate it.
All right, and so no opposition. We'll consider those meeting minutes from our June meeting approved and continue on with the agenda. So today we have a new member of the MAC, Daryl Hershaft. I believe, Daryl, you're from the Utah Health Policy Project and would like to just give you a minute to introduce yourself to the other members of the MAC and those who are participating in the meeting if you're on.
Great, thanks. Hi. Yeah, my name's Daryl Hershaft. I am originally from Philadelphia, but spent a long time in Washington, D.C. In nonprofit work and consumer advocacy. I've been with the Utah Health Policy Project for 5 years or so. Recently became the director. So I will be happy to do my best to bring a consumer's voice to the table as someone who's worked with enrolling people and currently manages staff that does, several thousand enrollments each month. So I'm really delighted for the opportunity and thank you for having me.
Great. Thank you, Daryl. We appreciate your introduction and we welcome you to MAC. It'll be good to work with you. Okay, we do have a couple of other vacancies for different positions on the MAC as noted here on the agenda. We have an opening for a consumer rep for the business community, as well as a provider rep for the dental provider community. So if you know anyone representing those areas and would like to help them submit an application, you can connect with Sharon and she can solicit their nomination information and make sure that gets considered for appointment to the MAC. Okay, any questions on that? Great. Thank you. All right, we are going to make a few adjustments on our agenda. Jen is going to be joining the meeting a little later, so we'll move her down further into the agenda to make sure we wait till she gets here. But we will proceed, Gina, with you as the eligibility enrollment update presenter, if we can start there, and then we'll move to other topics as we have occasion for the presenters to be.
Sure. Thanks, Michael. Give me 1 second here while I present, and I'm just going to put a link in the chat, a couple links in the chat for everybody. Give me 1 second while I grab that. So as Michael stated, today I'm going to go over the eligibility enrollment report, just covering for Michelle today. I dropped a couple links in the chat. This information is available on our medicaid.utah.gov website. On this page, I am on the persons page and under the interactive graph. So for the month of July, our total enrollment for the month of July is 105. On the next tab, so within this page, there is a data tab as well. So I'm going to highlight a couple items on the data tab. This data tab does have a little bit more information. It is program specific. As you can see, I'm not going to go through each of the program, but I just wanted to highlight a couple things about it. As you look at these numbers, and for the month of July, we have the pregnant woman. So since we extended to 12-month postpartum for the pregnant woman program, the numbers are still increasing. So as I scroll down, we are now at 12,923. And another program to point out, as well as CHIP. CHIP has also increased as well. It has been increasing, let me just say that, for the past few months. So other program numbers, it looks like they are stabilizing because we are no longer in unwinding. So looks like those numbers have started to return to normal levels. Let's just say that. Moving on to the CHIP, state CHIP, I just wanted to point out that on the state CHIP, so as of August 12th, we have 1,492 children on state CHIP. We can cap out at 2,000. So since we implemented this program effective January 1st, we are now at 1,492. And I'm going to pause right there. Yes, Rachel.
Great. Just a quick question. This is about not state CHIP, but the medically needy child program. My understanding, it's different than the medically complex child waiver. That one's dropped quite a bit. I'm just wondering, are kids now like underneath that program, are they generally being covered under the complex child waiver? Because I know that Representative Elison had grabbed some more funding for that waiver program maybe last year or the year before. I don't remember exactly when right now, but I'm just wondering, are you seeing like transfers from the medically needy child program to the medically complex child waiver, or the population that's covered under there? You might not know off the top of your head.
Yeah, that's a great question. I'm going to have to take that back, Rich. So I'd have to look at the data a little bit more, but maybe Brian just raised his hand. He can help with that, but I'd have to actually look at the data a little bit better.
Yeah, thanks for the question, Rachel. I can answer probably half of it, but we may need to return to it. In eligibility terms, medically needy is essentially spend down. So it is different than medically complex children's waiver, and I don't think that's the explanation. Although it's possible children are moving over there, I don't think that would explain most of the movement. So I think we'll need to come back with a different explanation of why that has decreased.
Yeah, because it could, I guess, yeah, you're right. It could be a spend down issue. If they can't afford the spend down, they're being disenrolled that way. Because it's just like, it seems like it's a pretty historical low. There's like 20, there's 20 individuals on it right now.
Yeah, that's a good point. We will look into that. Thank you. One other supposition is that the numbers increased quite a bit higher during the public health emergency because essentially a family would only have to meet the spend down 1 month, and then for the duration of the public health emergency, they would be kept on regardless of spend down capacity. And now in unwinding that changed, that could explain a lot of it, but we'll look into it. Thank you.
Thanks.
Were there any other questions before I end? Thanks, everyone.
Thank you, Gina. We appreciate that and going through some of those specific categories and teasing out the details. So we had a little more visibility to that. That's very helpful. And Brian, thanks for your additional insights there. Okay, like I said earlier, we're going to skip Jen's report right now because she will be joining us later. So we will move on to agenda item number 4. Joseph will talk with us a little bit about HCBS support services access and adequacy of providers. In our last meeting, this was a topic of discussion at the very end of the meeting and requested that we put it on the agenda today for a little more discussion about the challenges many families are having with trying to get adequate provider access and get the needs of their children met on some of these programs. So that's what we're hoping to accomplish on the discussion, but we'll start with Joseph with a little background, and then we'll talk through some of the challenges families are experiencing.
You bet. Yes, thank you, Michael. Thank you, committee members, for having me. For those who don't know who I am, perhaps, my name is Joseph Ambernack. I'm the director of the Office of Long-Term Services and Supports. Our group provides oversight to the 9 home and community-based services waiver programs, in addition to operating 3 of them within our group. We're tasked with the responsibility and usually are the party that communicates with CMS regarding waiver operations and a lot of the policy guidance there. Tacking on a little bit to Michael's explanation, we also had a handful of specific questions with respect to how does DIH evaluate the adequacy of the home and community-based services provider network? How do we measure this? What can members do to escalate situations to ensure that they are getting the services that they have been assessed to need? What can members do to help gain access to them if they are having a hard time finding a provider? Where can individuals provide feedback with concerns? So trying to touch on a few of these pieces. We've got a significant chunk of time on the agenda, hoping to make this more conversational as we go. But as Michael mentioned, we'll provide some background as well for you, kind of how our provider enrollment process works, how service planning and assessment works, and maybe a few of the different pieces surrounding some of our waiver programs where we do partner with entities like the Division of Service for People with Disabilities or the Division of Aging and Adult Services in their operation. A lot of similarities exist between the programs, but there are a few specific differences that may be helpful to call out and discuss as we go. So also assuming a little bit that in the public hearing and testimony that's been shared in recent months about providers who are leaving waiver programs, a lot of concerns primarily stemming from reimbursement, but assume that this is probably where some of this agenda item has gained some traction. So please feel free to rein me in at any point if I'm kind of departing from where you're hoping I go, but just starting with kind of a few general pieces that are important to understand. So the first is that all 9 of the home and community-based waiver programs operate under the fee-for-service model. We accept any willing and qualified provider who meets the program requirements and the provider qualifications, and then agrees to accept Medicaid reimbursement at the rate masters that we have established. So in most programs, providers will also indicate what counties of the state they intend to provide services in, as they may not be in operation statewide. That's usually a piece that we capture during their enrollment process as well. Something that is also unique to the waiver programs is the use of self-directed or participant-directed care. So this allows the individual or family to be the employer of record and allows them to hire their own workers to perform care for a number of our waiver services. All 9 of our waiver programs use self-administered or self-directed care in some fashion. We usually, in our application with CMS, we call out the specific services that may use that authority. but it can allow the individual to hire friends, neighbors, family members, and due to recent or legislation passed in recent years, it now includes spouses and parents and guardians of the waiver participant. So any of those individuals can be selected in order to be direct caregivers. In order to facilitate this arrangement, we have the individual partner with a financial management services agency. They help them with things such as the completion of employment forms during that onboarding process, the background check process, any tax withholdings that are necessary to collect for IRS purposes, processing of timesheets, and that also involves billing Medicaid for the services, and they aid as that pass through to get the funding to the employee. So, most services offered through the HCBS waivers, by and large, do not include a clinical component. We know obviously many do, such as our technology dependent waiver, but allowing for this self-administered, self-directed option can often aid with a lot of participant autonomy. And honestly, it does help us as well with some of the concerns that we have seen with provider access and understanding some of the barriers with agencies performing care. So in all cases, though, whether it be the self-directed model, we do work to ensure individuals and agencies who are brought on are able to meet the support needs of the individual. This is primarily done with our case managers and support coordinators. They conduct those initial assessments, the care planning, and then also provide routine monitoring, typically on a monthly basis, which can include in-person or phone checks to evaluate how the delivery of service is occurring, or any concerns with that. The case managers and support coordinators, of course, fulfill a critical role then as well in troubleshooting any of those care delivery issues with the family, and become the waiver participant and others associated with their care. They are usually that point person or immediate contact with any direct concerns. A lot of our staff have become very adept at navigating Medicaid state plans. Several of them have been able to help families with EOBs that they may be getting from their private insurance, or their explanation of benefits. When they're having trouble with their third-party insurance, they frequently are a Swiss Army knife for families, where they have learned a lot over the years in various ways, and have kind of adapted to try and find ways to assist families. So during the care planning process that occurs on at least an annual basis, certainly when families are coming onto our program, assessments are performed. Each program does use a different kind of assessment, both to establish level of care that's necessary for our programs, but also for the needed services that the individual has that the waiver offers, trying to see if they can be filled by other Medicaid state plan services, or potentially natural supports, and then looking to the waiver then to see what should be supplemented or provided through our supports. This process takes on a couple of different forms. For some waiver programs, we provide a list of the enrolled providers who may be in that catchment area or that regional area, and then work with the individual to look through or to evaluate which providers make the most sense for them to hire, which can meet their needs, perhaps with the time of day they require service or how frequently they require service, trying to figure out if that's a match between the provider and the individual or family. The other, and is commonly used frequently by our partners with the Division of Services for People with Disabilities, some of the individuals on our intellectual developmental disability waiver programs can be very complex from a behavioral standpoint. So what we frequently do there is what's called an ISO process, or invitation to submit offer process, where general information about the support needs of the individual and family are provided, and then we work to gain provider interest and solicit from them when they have the ability to serve that individual or family. So a little bit of perhaps the opposite scenario. And then if there are multiple responses, we then work with the individual and family to select from among them, or in the case where it may be perhaps difficult to find a provider, go through that ISO process again if necessary. So I think a good example might be for a residential placement for a provider who may be performing around the clock care. The individual or family may have a very strong preference on where they would like to live as far as geography within the state. Maybe they would like to be close to family, friends, perhaps their employment opportunity. Certainly depending on where that may be, provider selection might be a little bit easier, might be a little bit more difficult depending on what those are. For example, if somebody is very adamant, for example, about living in the Price area, we may not have an immediate placement available, or we may have a provider with an immediate vacancy. It's always a little bit difficult when we're trying to do that match. Another piece as well that is relevant to our programs is that we are unable to pay for room and board through the home and community-based services waiver. So the individual is responsible for a room and board component. Certainly depending on their finances, that can create limitations for where they would like to live or the type of facility. I think we commonly see this with our New Choices waiver program, for example. Assisted living facilities kind of set their own expectations for what our contribution through the waiver program is in conjunction with what the member is able to pay as part of that total reimbursement they receive. So some facilities may or may not be available depending on financial circumstances. And more so just with the, directly with the question on when an individual may be experiencing concerns with provider availability, or perhaps just quality concerns with a provider who may be missing a lot of scheduled appointments. The case manager or support coordinator is often that lifeline to try to work with to find a solution. So, and increasingly due to reduced options of providers, it could be trying to find maybe other services within the waiver that are similar, but maybe slightly different. So for example, companion services, attendant care, or homemaker all kind of fall within at least a similar umbrella of what they provide care for, with some distinctions, of course, with the scope of work. So that could be a method that the case manager or support coordinator uses to try to fill that need. Maybe looking at self-directed care as an option to try and see if the family may be interested in that as well. But we recognize too that the way that services exist today, families are often going without the full complement of services that they've been assessed to need. Sometimes not at all in certain situations or different areas, as we try to resolve some of the concerns. But and then more with respect to the data tracking and requirements of the waiver program. But the home and community-based services waivers do not have performance measures or data tracking surrounding provider network adequacy. The authority that drives the waiver programs, it is different than, for example, our managed care authority. Or other pieces of the Medicaid program where that is a required reporting element or a demonstration that needs to be made. But with respect to the access rule that we spoke about, I believe it was in last month's meeting, and I apologize, I'm a bad historian at times. Information surrounding provider reimbursement rates and for several of the services, a confirmation of how much of the reimbursement is reflected in direct care wages. Those are going to be pieces that come online within the next few years, in addition to a measure that expressly requires the state to track the length of time from when an individual is assessed to need a service to when they actually begin receiving the service. And that will be part of data that we are required to publish and make available. Those portions, obviously, it still doesn't answer that question necessarily about network adequacy or perhaps areas of the state where there may be a lack of providers, but it can certainly help support some of the decisions maybe for additional funding in the future, or at least help bring awareness to underserved areas of the state. And maybe just something based on the feedback that we've been getting from providers as well. But a concern about using provider counts in various geographic areas as part of that demonstration of adequacy could be a concern based on kind of the information that have received, but many providers who remain active Medicaid providers have told us increasingly that they are unable or unwilling to accept new participants. So while they may be carrying out service to the families that they may have made a commitment to, many are not taking on new clients at this time. Some are hoping for some traction with reimbursement changes with our programs, perhaps not formally declaring that they wish to disenroll until they're able to see the outcome of perhaps the upcoming legislative session, for example. And again, others continue just to provide services to the families they've made a commitment to, or in the case of some of our assisted living providers, many have told us that they remain enrolled on the program for those that may have been private paying within their facility. And when their financial means are exhausted and they switch to Medicaid, they also continue to or wish to continue to make that commitment to those individuals, which is why they remain on the program. So I think numbers, or at least capturing those nuances, that would be very helpful. I think that level of transparency would be very helpful in understanding, again, a general provider adequacy piece. We would be talking about either monthly, quarterly, annual updates from providers in order to maintain that information between service systems or between different waiver programs. We're talking upwards of potentially 1,000 providers where we would need to kind of keep that information up to date as well. So just, I think important to understand that just simply because a provider is enrolled may not tell the entire story related to their ability to and capacity to serve new participants. Sorry, and then just in general, it seems very clear from the information from the public hearing that the provider perspective is that the financial viability of services within our programs is in question with current reimbursement levels, and then how much they are able to pay their direct care staff. We are also participating, or sorry, DHHS in general. I want to acknowledge our partners at the Division of Services for People with Disabilities and Aging and Adult Services. We continue to participate in conversations about direct care workforce, trying to find other strategies that can be used to try and promote and support the caregiving profession. Many of these or other supports could be non-monetary in nature, and we're trying to see all of the avenues in which we can, again, promote caregiving as a very noble profession as it is, but understanding that reimbursement has to be important, but allowing for us to learn from our national partners about how to attract, retain, and support direct care staff, and certainly the families and individuals who rely on these supports. There's a lot of different strategies we could employ and trying to make sure that we're opening ourselves to as many of those as possible. So I hopefully conveyed helpful information. I'm not sure if I was able to touch on maybe the general questions that you were hoping to hear back. Yeah, please feel free to drop questions in chat, or Stephanie, do you want to get us started?
Yeah, and sorry, I don't know if I'm going to be easy to hear, so I apologize for background noise, but I appreciate all of this. This was really, really helpful. You might have said this, but I was taking notes quickly. Do you have it, like, what are we compared to, like, nationwide average, other states, like, who's retaining caregivers, like, this particular part of the caregiver workforce the best, and what is their reimbursement rate?
Yeah, and we are, on a regular basis, we are working with our accountants within Medicaid and DSPD, as well as in the middle of a rate study as well for their programs, to try and answer a few of those questions, where we are in line with other states, understanding how Utah compares in general from an economic standpoint. We know with cost of living drivers that it's not equitable across states. Certainly surrounding states or ones that are similar to us would be helpful to understand where they are in reimbursement. Certainly a lot of providers have been very open to us with respect to where they need to be from a cost perspective, just in order to cover their expense of employment and the overhead necessary. So we are evaluating those. It is something that we do perform on a recurring basis. The difficulty with a few of our supports, for example, is to conduct a very thorough study. For example, for our residential rates with Division of Services for People with Disabilities, there's a lot that goes into the establishment of what a daily rate to that provider should look like. So making sure that the assumptions that were made based on studies 15, 20, 25 years ago, refreshing that data and making sure that those foundational aspects remain relevant as part of that reimbursement. So we do have a lot to do in that evolution and rate development, and we're hoping to provide better information for lawmakers so that they can make informed decisions. I think right now, again, providers have been more than willing to open up their books to demonstrate today's expenses, but I think we do have some foundational work on how to establish a rate, and then maybe even some recommendations on how to engage in a more regular increase that accounts for inflation, where a number of our programs, for example, have not had rate adjustments that have been relatively substantive in about 10 or 12 years, which I think those who have experienced the inflation of the last 3 to 5 years know how if we are intending or trying to pay the same rate as we were 5 years ago, that there's just kind of a understanding that that's probably not tenable, or certainly that there's been a lot of contraction in that provider being able to make that rate work.
Thank you. That's helpful. Yeah, I think it is just one of those things where I feel like, and I apologize that this is probably like a redundant request, and I apologize if like you guys have done this and I've missed it, but I just think like there's areas where it seems like, you know, there's rates that we set, and I apologize for throwing certain entities under the bus, but I just keep thinking about like a hospital assessment that was given to hospitals where it allows them to have more funding. And I just worry about some of these other provider groups that are so behind in terms of funding and the way that it impacts people's lives in such a real way. I really appreciate that you guys are doing that work. And I think it's important for us to be able to understand, like, and for y'all to be able to understand, and lawmakers, like who is like the most, where are the greatest disparities in rates and providers and just access. And again, I just think that's so important, because I do think some of these areas are just like so woefully underfunded. And I mean, the provider rates not being adequate, and like, then like, you know, the way that trickles down to access, and then just thinking like we've got the whole other thing of the wait list. Like, it just feels like it would be so overwhelming to have some of y'all's jobs, and I appreciate what you're doing, but we just really need to be able to have like a clearer understanding of like, where is there money that's maybe being like overspent and over allocated, and where do we need to make sure that like funding is being spent in a way that, you know, better benefits, you know, the actual tangible lives of Medicaid beneficiaries. And I think this is really important. So thank you for your work on this.
Oh, you bet. And the funding that we received for the recent rate studies, much of that did come from the American Rescue Plan Act. It is something that obviously we see immense benefit in, as a lot of our providers, and I think this commentary was shared during the public hearing, many of them are unaware of how to advocate for rate changes. Many of them do not know of the Medical Care Advisory Committee, do not necessarily engage with lawmakers. A lot of these provider groups are very small in nature and don't end up having a very strong voice as a result in that lobbying. And not that we are necessarily in a position to lobby directly with lawmakers, but certainly trying to establish policy that might help move forward and have a general increase maybe adapted into the rate setting process. So we're not kind of running into this problem on a recurring basis. And certainly from lawmakers' perspectives, they were very responsive to needs in DSPD system in particular during the public health emergency. I believe it was just shy of a 20% increase across the majority of their services with direct care components, which was incredibly generous and badly needed. but it did not cover the aging and disability side that we see with our new choices waiver, our tech waiver, medically complex children's waiver. And from a lawmaker's perspective, it was a little bit frustrating where they made that significant investment in services only for a significant portion of our provider community kind of raising their hand saying, what about us? You kind of missed us over here. So I can appreciate both from, again, the lobbying perspective of individual providers, and then even from lawmakers, it's very difficult to keep track of, again, a lot of very necessary services that help with family safety and autonomy. And we're trying to help bridge that gap where we can as well.
Okay, Colleen, you were the one who requested this be put on the agenda, as I recall. So if you would like to take a minute and maybe share what your personal experiences or those you work with, just what it feels like as a family trying to deal with some of these circumstances in real life, aside from all the structures and the analysis. If you'd like to just share that with the committee and try and bring some real experience to the discussion, please.
Thank you so much. It is hard to it is hard to hear it from, like, again, the administrative or like the legislative side of it when you're living with it. And especially, again, my perspective, I also get to hear a lot of other families' experiences. So I just want you to take a minute and imagine, you know, so we have my family has a 26-year-old daughter that has very severe support needs. So it's not about, you know, her long list of disabilities and challenges. When we're looking for support through DSPD or from state agencies, it is to fulfill her quality of life. Again, it is not just like, oh, I need a break. I just need help. Because again, legislatively, administratively, our neighbors are saying, well, why can't you just handle this within your family? We would love to. I'm not mom. Like, I will keep my kids home and under my roof and under my helicopter mom forever. That does not provide them a quality of life. I understand that. So again, even at a certain point, the services that we would reach out for or that we can do by ourselves within our community can't be fulfilled for her without what we call, you know, supported living, something that's more age appropriate, that does have a goal base that we can track progress through, but that we do have to pay additional support staff to. So that also includes, again, all these things that families are not equipped to handle. Fiscal agents. I'm not a payroll manager. I don't know about taxes for employees, things like that. Like that, those are services that DSPD provides to my family that I'm very thankful for. Workers' comp. We went to the legislator and fought for that as well. So again, I have a daughter that it's very likely that when she's in the community or when she is with staff, something might happen. And I want to make sure that that staff is taken care of. They become part of our family. We rely on them to be healthy and for their safety as well. And so that was huge for us. But I can't just do that as an independent mom living in Sandy, Utah. So again, to have that be able to be facilitated through these programs and through these waivers now is super, super great. But again, in those supports, turnover in agencies really does affect her. It's huge. And I know it's a problem across, you know, a lot of different organizations and medical things and everything, but turnover for my daughter and my family is something completely different. I mean, it takes months sometimes to train. Through person-centered plans, which we do also get facilitated through our support coordinators and things. And there's a lot of great tools that families that aren't on DSPD can use to create person-centered plans and everything, you know. I feel like I could, you know, possibly send a manual on my daughter with somebody, you know, like, oh, here's, you know, the time she gets up, the things she's allergic to, all the medications that she takes. But it's different than just the hands-on time with our family and coming into our home and seeing the things that that she needs and that she's used to receiving services for. But again, when with that 20% rate increase a couple years ago, that barely brought them up to the same wages as some of our fast food restaurant employees. And as happy as we were for that, it's hard to consider. I mean, sometimes I feel like, I'm sorry, my daughter's worth more than my tacos, you know, like I think that they need to be taken care of better than that. I consider that to be a higher level skill, but it also doesn't create any career path for these individuals. So no matter how much they're being paid, this isn't something that someone could ever raise a family on. It's not something they look to for opportunities for career advancement. And a lot of times, you know what I mean? So we get these really great employees that are super into what they do while they're in school or while they're young. And then they have to get married. They have to have their own kids. They have to have real careers. And this is not the industry that they look to do that in. And so we lose so many really great, compassionate people in this workforce to, you know, wage and career discrepancies. And I think that that's also, you know, when you talk about direct care promotion, I don't know how to sell this as a great job forever. You know, I'm like, it's a great opportunity for a college age kid for a girl that just wants to, you know, be able to take my cute daughter out to Target and to do important things in the community. But I can't imagine it being something that, you know, sustains someone without personal passion and commitment to it, if that makes sense. So again, these are all really important things that I feel like do come back to that rate study to prove to our legislators how important it is. But that's something as a family we also promote and do is I'll invite my representatives to my dinner table a couple times a year. They don't always show up. You know, our current one has never been to my home, but I link him in all of my Instagram posts about her. She has her own Instagram page. I make sure he followed that so that they see what our family looks like. She is his constituent as well as me. He needs to be representing her as much as my other children and my husband and my next door neighbor. And so to have them have that opportunity to see how that affects us directly, I think is really important. But I really appreciate you, again, looking into these things because we know that they want numbers, they want data, and I have no problem. You know, again, it's pretty easy to find that. It's just, it's getting the buy-in.
Great. Thank you, Colleen. Let me just ask if anybody else has any comments or questions. I have several lines of questioning that I would like to go through and maybe just continue the discussion, but just curious. Anybody else like to chime in from experience or things they have heard from other people they would like to share? Okay. And oh, yes, please go ahead.
Sorry, Michael. I apologize. This is Matt Hansen, the Executive Director of the Home Care and Hospice Association of the state. Thank you, Colleen. Appreciate it. We see this every day, right? I mean, yeah, it's extremely difficult, and I think everybody's aware of the difficulty, but we just need to keep on coming up solutions with this because it's the funding of the programs, it's being able to pay a caregiver sufficient reimbursement. Like you said, it's never going to be something that somebody can live independently on and pay for a mortgage and things like that. But it still needs to be enough to be able to help to keep them in the industry. And, you know, that's one thing that we try to advocate for in the reimbursement rate. So we can even keep these programs open because we are worried about some of the HCBS programs and just not being able to sustain them. We're seeing fewer providers outside of self-directed care. The providers and the agencies, we're seeing fewer providers even participating in the programs because they can't make it work. And they have to be able to, you know, pay their own mortgage and put food on their table too. So it's extremely difficult, and appreciate your awareness of this and the situation and advocating for it.
Hey, and Michael, if I can just add to what Matt said, this is Dave Park. I'm the owner of Home Instead. I've testified here before, and you've heard the story, but just to give a quick update, the aging waiver program that we've been participating in for about 12, 13 years. We are an active provider, but I only have one client. 5 years ago, before COVID, we had as many as 30, but I've had to drop, and it's gut wrenching, but we had to discontinue services for multiple people, and we've just never taken any more on. But I'm one of the providers that shows that I'm an active provider, but I have one client. And the only reason that we have that one client is because she also has a Medicaid state program through an ACO that we provide care for. So we can kind of eat the losses that we have with her in that with the aging waiver program. So just throw that in there. Thank you.
Great. Thank you for that additional perspective. Yeah, I think these are some of the things, of course, the public needs to understand, the decision makers, the legislature, the department. Couple of thoughts. Every legislative session, there are initiatives to take people off the DSPD waiting list, which is one of the waivers that the state administers. But if we're taking 100 people off the waiting list per se and putting them into services and there are no providers, what is the value that the state is really delivering on? Do you have a comment on that, Joseph? Because I think if you've waited on the waiting list for a dozen years and then you finally get selected to put your child into services, again, maybe an adult child with a disability, and you think, okay, finally our wait is over, we're going to get some relief, and then you can't find any providers, what is the best avenue for those families to get help getting services?
No, and you're exactly right. And it is something we are experiencing on the aging waiver program as well. But it feels like you're placing a house on top of a broken foundation where it looks great as far as perhaps the numbers of the reduction of individuals on the wait list. But in practice, it doesn't offer a lot of meaningful adjustment if the supports that you're reliant upon are not readily available to you or available at all. But part of that does amount to work within our provider group to find out where they are capable of expanding within the service system. And I do have some support here from Amanda Barr with the Division of Services for People with Disabilities, if there's anything that she may like to add as well. But I mentioned that invitation to submit offer process that they use. It has meant for administrators at DSPD as well, when the provider response to those offers has gone out, that they have had to work to contact providers directly to try to find it if they can expand capacity to help serve those areas, serve those families. The advances that we've made on spousal and parental guardian caregiving are fantastic, but and I think to maybe your point, Colleen, is for a young adult, care at home with family may not be the best way to grow their own social development and help them lead the life that they would prefer to choose. So I think we're kind of in a combination of pressures where both to help drive individual autonomy and then certainly to provide relief to families and the support they require. It's kind of an ongoing battle to continue to try to work with providers who, again, have done the best that they can under these constraints as well to assist. I know I did not directly answer your question, but I think it's very much the problem of we continue to try to troubleshoot on a case-by-case basis and do what we can when we are able. And for the aging waiver, for example, it has meant that they have left funding on the table at times, because they know by bringing on an individual who may reside in a specific area of the state, because of the deficits in the provider network, they know that it doesn't serve a purpose, frankly. So I think we have tried to be careful when making those commitments with families when we know that's not possible. But in general, and again, our case managers and support coordinators go through incredible efforts to try to link families to, frankly, any support and hopefully the support that they've been assessed to need.
Okay.
Matt really nailed it. You know, it's just a new wait list that isn't publicly visible. Like really, I try to help families understand like the grass is not always greener on that funded side, because there's still a lot of work that a family has to do. You're not done advocating. It's a lot of hard work and waiting still.
Okay. Amanda, yes, please.
Yeah, absolutely. So my team is the one that we're bringing people in off the wait list. I have 8 members on my team. We're going through bring in as many people off the wait list as possible. And it is very, very difficult finding providers. But as the longer we've been doing this, I've been supervisor for my team for about 3 years now. The longer we do this, the more relationships we get with providers, the more we understand kind of how it all goes. And my team also runs the ISO list. So we're out there. I can look up providers. I actually had a provider call me today in response to an ISO asking, hey, this is the people live about an hour and a half away from anyone. They're in Kanab, Utah. So if anyone's ever gone out to Kanab, Utah, it's kind of the middle of nowhere. And because I know the area, I messaged a whole bunch of support coordinators that I've worked with and said, do any of you have any people in this area that need a provider? I have one that might be willing to work if they have a couple different clients. So we're slowly building up, building our spider web to go all over the state. We also have another person that we're working with right now that's a member of DSPD that he's going out to these rural areas and saying, what can we do? So a lot of the issues we're having are in the rural areas. Not to say there's places that aren't rural that are still having problems, but we're trying to get more providers and more words for providers, try to get them a bigger voice by making these connections. So it's a slow process, unfortunately. And if there's, where we see an issue, we're working on trying to fix it. It's just a lot of time, unfortunately, but we're definitely trying to get these providers going. And
a lot of crisis management, I'm sure, given the challenges, because the economics have to work for the providers. If they're thinking if they're going to try and add staff, they have to be able to pay them. And if the reimbursement rate is less than cost, then obviously that's not something you can make up in volume. So,
and we have to give a choice as well. We have to give a choice to the clients. Do you want to work with that provider? And if they say no, then we're, kind of back at square one, because they do deserve a choice. They deserve a choice in what they want to do and everything. So it's definitely a balancing act and trying to get everything just right. But I think we're definitely onto something good now. So.
Well, we appreciate the crisis response team that you're managing and the efforts you're making to try and get people access to care. Let me just ask the department or many of the providers if we could just have a general comparison of Medicaid's payment versus Medicare's payment and a commercial payment for these types of services, just to raise the visibility for the MAC of how far behind the market Medicaid's reimbursement is. Dr. Britton?
Well, I know that at least in primary care, Medicaid reimbursement covers about 60% of overhead. So it doesn't even cover overhead for a primary care visit in pediatrics, at least, or family medicine. And I realize that this is different than the in-house, on-site providers, but even the physicians are not getting anything close to what we get. And as you guys point out, we can supplement that by having other patients with private insurance kind of help supplement that, depending on what our caseload is. But I realize if we're seeing that, how much worse it must be for the teams that provide in-home care and respite care and on-site care and group homes and helping the families, with the different waivers. It just must be so much worse for them. So I'm eager to hear their numbers too.
And sorry, Michael, perhaps interjecting perhaps while providers may be thinking about this, but with some of our rate contractors, a problem that does exist within the home and community-based services realm, and our waiver authority in particular, is we can really define the scope of work from the ground up. So there may not necessarily be a direct equivalent in another surrounding state or perhaps even in the country, which can be problematic in trying to find a comparable. Certainly several of our services are personal care like, where that is a little bit more ubiquitous, and we can see similar programs. But we have tailored many of our services to respond to needs of families as they have provided them, which makes entities like our auditing or accounting agency, again, it makes it very difficult for them to find the same set of conditions for the same provider education requirements that we may have to find those that they can say Utah is paying less than, similar to, or more than a surrounding or nearby neighbor, which does make the comparables a little bit more difficult. With the DSPD programs as well, we know those providers, their revenue source is nearly 100% Medicaid. So we are the payer in the market. There really isn't an outside entity that assists. On our New Choices waiver, for example, we find almost the inverse, where for many folks out of a 50-bed facility, they may be serving 1 or 2 Medicaid participants. So it's almost, many of them have framed it as almost a charity arm of their business, where perhaps to Dr. Britton's point, where private pay is then supplementing or allowing them to be a participant in our program. So yeah, sorry for the tangent, but wanted to offer that.
And that's a good point. While people are gathering some of the information, the mix of patients is a very relevant part of a provider's assessment of whether they can take a certain volume of Medicaid patients. And if it's exclusively a Medicaid service, then that's not one, again, where you can cross-subsidize from better payments from other types of payers. So those are, I think, a few of the dynamics that I think the MAC would be interested in saying. You mentioned this ARPA-funded study you're doing on trying to picture things. Obviously, if you don't have comparability of services, it makes it difficult to convince legislators that they need to make a rate increase commitment. But to the extent you can benchmark similar services, similar types of qualifications for the delivery of care, and show what the Medicaid payment is to Medicare and to private commercial payments, if applicable, I think those usually tell a pretty good story about where we're at. And then if the study could show, similar to the discussion, how many people are in service today and have been in service for how many years, and providers are willing to provide care to the existing group of people and services, but how many providers are taking new patients, and what does that experience look like? And maybe even some type of case study samples from people whose children came off the waiting list in the past year, what their experience was like in the current environment to try and get access to care. Because the department absolutely has a legal responsibility to ensure access to care. And despite the legislature not funding that, the fact that the rates aren't adequate to ensure access to care does put the department at risk for a number of interventions that could come if those rates don't get increased. So could you just kind of speak to that as an agency, how you assess your risk in terms of non-compliance with federal law based on your current rates?
I also just just so you can think about this too, Joseph, again, when we're talking about comparison of services, even when there is a direct link, you know what I mean? Again, like you said, home health care. I need home health care for my daughter to help her with activities of daily living. But the type of support or the type of things that support that she needs because of her behaviors are also going to be very much more, it's going to be different than somebody going in to help, again, someone through the adult and aging services waiver. If that makes sense. Like, she's going to have behaviors, and maybe this group doesn't understand when I use that, but I mean, we're talking, she's hitting, she's screaming, she's self-injurious to get through those processes. And so we sometimes supplement on top of DSPD funding because of the extraordinary care and services that her supports need.
So I can step in. I mean, I think a big transformation is the access rule that we are still looking to implement. It did change a lot of our responsibilities, uh, doing away with kind of the antiquated access monitoring review plan that we've done in the past, but also requiring new things like 80% of reimbursement going to direct care workforce. So, I mean, that's the landscape that we're looking to comply with. But I mean, I don't have a lot more than what Joseph said about like our efforts engaging with peer learning collaborative to try to advance our direct care workforce and
So
certainly.
I understand the compliance structure you're looking to adhere to, but at a higher level, just in terms of compliance with federal law and a general assurance that you're providing access to care for any service that you're paying for as a Medicaid agency. And if you aren't willing to say it or don't feel you have the ability to say it, I think we need to raise the awareness that if the state doesn't raise the rates of payment to the providers, then there are different groups that could step in and sue the state and take it to court for non-compliance for complying with the federal law of access to care. And this could put the state in some type of a receivership program or a court monitoring activity if it becomes drastic enough. So I think, those are some of the dynamics that I think people in the community experiencing this are not wanting to have to take on. But the federal government does have a role in overseeing the state's implementation of the program. And if there's enough of a compelling interest, it does subject the state to a risk, not saying it's going to happen, but of the federal government stepping in and saying, you as a state agency or as a funded state agency from legislative appropriations aren't fulfilling the requirements under the program as it's been authorized. And we, the federal government, are stepping in based on somebody filing an appeal. I mean, I think everyone would hope that isn't what it has to come to, but there are avenues for people to intercede if action isn't taken by the legislature to provide the rates. And that's, I think, a risk just to raise for surface of discussion. So
We're seeing lawsuits. They're in.
okay, so it's already underway. Okay. All right. Any other topics that people would like to bring up? I think very real world application of how the programs are actually being implemented, the challenges providers are having in terms of delivering care, and the challenges that families have in terms of trying to get access to their services. And I think the ask of the MAC would be, as you're looking at the study, trying to depict some of these things that have been brought out in terms of comparability of reimbursement, percentage of Medicaid patient mix in providers and their ability to shift costs to other payers, and where the crisis really ends up being and what the experience of people coming off the waiting list is. Because I believe the top several items the MAC had voted on in our meeting in June after the public hearing in May was to address some of these issues. So I believe everyone understands it's a problem. Not everyone is in a position to do it, but if we can have you be as effective as possible in highlighting the crisis level of reimbursement, the challenges these providers are having, just trying to stay in the business, I think that would be helpful. Yes, Stephanie.
Yeah, I'm just wondering, I know Rachel kind of also made a comment to my comment in the chat, but like, is there anybody from legislative staff here? And like, I just feel like, how do we get them to, like, the MAC, I think, needs to take a stronger role. And like, and I realize maybe the bylaws don't like push this, but I just think we need to write more, we need to engage more politically, because I just feel like there has to be a way that we help them to know about the conversations that we do have here. And I do feel like if, whether it's that they come whether it's that we have like quarterly meetings with that. I just feel like there needs to be some kind of effort to make sure that like the policymakers are like getting the information. I mean, the governor's office like should be like, they need to hear this. Like I just feel like it would be helpful. I felt like this obviously all during the unwinding. I just think there needs to be ways that we get that up to the top of like who are the decision makers. So I would love to know, Michael, like what your opinion is on that, and like if there's any opportunities. I have heard that other states have like done like I don't know, it seems like there's some states that do use their Medicaid advisory committee in a way that, you know, where they take positions and on bills and things like that. And I'm just wondering if there's a way that we can try to engage a little bit more politically.
Well, yes, in reference, like you said, to the MAC bylaws, which could be subject to change, but as they're currently constituted, and the role of the MAC as contemplated in federal regulation is it is a body that is advisory to the Department of Health and Human Services. So I think we're achieving our role in terms of advising the department of the need, challenges in the implementation of the program. If the MAC wanted to take additional steps, I mean, that's always something the MAC could contemplate. And since today is my final day as chairman of the MAC, you can look to your new MAC chair and vice chair to contemplate some additional, well, there we go. And I'm not disputing that it could be more engaged. I'm just saying every state has a very different political environment as well. And whether it will make a difference and be helpful or hurtful is also a judgment call. And I've seen a lot of advocacy at the state that actually antagonizes the legislature and people don't get things done. So I think a good deliberative process of informing but not shaming is an important way for us to contemplate any attempts we're trying to make in legislative policy appropriations. My approach is more direct diplomacy and not more aggressive advocacy, but under your new leadership team starting next month, there may be a change there. So I will totally leave that to our new chair and vice chair to contemplate any additional measures the MAC would like to take. So with that, we do need to move on to our next item.
Michael, it's Andrew.
Yes, go ahead.
I was just going to. I had two quick things. One for Brian, and I know you probably can't speak to it being in or out at this point, but I'm just wondering if you know whether these issues have been brought up as part of the department's conversations with the governor about potential items to be included in his budget, and if so, what have to the extent that you know and can share, what have those conversations been like? And then secondly, to Steph's point, it's my personal opinion that if the MAC or a subgroup of the MAC wanted to take positions and advocate for those positions, I think I think the MAC could do that. And then if for whatever reason the MAC as a whole doesn't feel comfortable with that, certainly members of the MAC in their individual or organizational capacities could advocate as individuals or as a smaller group for issues like this.
Absolutely. Yes, that's longstanding known issue, and I appreciate that maybe raising the awareness to people who don't feel like they've had the individual opportunity to lobby. Okay, thank you for that. Joseph, thank you for your presentation and for the department as a whole answering the question. And Amanda from DSPD, is that right? Thank you for joining us today and all of your work in doing the best you can with the efforts of implementing the programs and getting services to the people who need them as best you can with the resources you have. And hopefully the upcoming session will have additional, awareness made about the need for funding these programs. Okay, our next agenda item is impact to Medicaid beneficiaries due to systems issues, specifically PRISM and eligibility. So as a little background, and then I'm going to turn it over to Stephanie because I think she has a little more real world experience in dealing with this. Over the last year, people understand that there's been a lot of disruption in terms of eligibility reviews and what that process has looked like for people losing eligibility on Medicaid. But over the past year and for some months, the department has also been implementing a new claims payment system that you wouldn't necessarily think would have impacts to eligibility. But one of the things that were brought up in the meeting and in other discussions is in many cases, people who are enrolled in a managed care plan are getting information that they are no longer enrolled in a managed care plan. And then if they're scheduling services, sometimes they're having their appointments canceled, sometimes they're being balance billed by providers for services because they are not showing up as an eligible enrollee in one of the managed care plans. And so I know we've spent a good amount of time talking about the eligibility determinations, but we're wanting to focus today more on the PRISM system, which is the name for the department's new claims payment system, raise some visibility to people about what some of the challenges are that people enrolled in Medicaid have had in terms of their experience, what that looks like. And so there are scenarios where even if an individual maintains his or her eligibility on Medicaid, they're losing access to care because of some of the PRISM issues. And so we've asked Greg Trollan to start with a little background on some of the things that have happened that maybe he's aware of. And then I'd like to go to Stephanie to share, again, some real world experiences and see, first of all, what we can do to raise visibility to the Medicaid enrollees about what they can do if they experience some of these issues, how to help navigate the challenges, and then see what we can do to try and remedy this. So Greg, please.
Yeah, thanks, Michael. I'm going to have Jennifer Meyer-Smart, who many of you are familiar with from some of her previous roles, as well as sort of staffing the MAC, but she is our assistant office director in managed healthcare. And she's been working to get information and then present for today's meeting. So Jen, I'll turn it over to you.
Yes, so we did previously have an issue that we had experienced since PRISM was implemented in April of 23, where members who were enrolled in managed care were being disenrolled from managed care or not re-enrolled and were ending up enrolled in fee-for-service. So we actually implemented a fix for this issue in our May 15th, 2024 release. So we believe that issue has largely been fixed. One issue we are aware of still is home members who also have a spend down. We do still see some issues with those individuals not being re-enrolled in the managed care plan, but it is a very small group. And so we are monitoring all of those manually and re-enrolling all of those. That's really the only issue that we're aware of at this time. And as I said, we were experiencing that from April 2023 through May of this year, where we were having members unenrolled in managed care and being put on fee-for-service, but that has been corrected. So we're hoping that we're not still seeing that. If we are, or if anyone has any members or providers continue to see that issue, we would appreciate you reaching out to our HPR group so that we can look into those and see what we need to do to resolve them. So I don't know if you have other specific examples recently where that's happened.
It's like Julie has a comment. So, Julie.
Yeah. Hey, Jen. So this is still an ongoing issue where we are seeing a bunch of issues with member enrollment. And I know that the state has a fix going in or planned with Essentra for October to address these ongoing issues. But we are definitely seeing enrollment issues still where there's issues with the enrollees' membership information coming over on our plans.
Yeah, and I mean, we're aware of the 834 issues, Julie, which is the CR you're talking about that's going in for October. But I'm not sure if that's this issue that Michael you're bringing up or Stephanie. But yeah, Julie, we are aware of those issues, and yeah, as you said, that will be going in October. But are we still seeing issues where people are moving from managed care to fee for service and they shouldn't be?
Yes.
Okay, and so you've made us aware of those, Leah. You've reported those to our data team.
When they come up, we do report them.
Okay.
I currently have our enrollment team holding on sending emails until we can, till I or Emma for Health Choice or myself for Health EU can review them before we send them over. But yes, it still does happen. It's obviously not to the same degree that it was in the past, so that's good news. But it is still happening.
Okay.
Yeah, and it is definitely still resulting in delays for member care. It's causing provider confusion. I mean, I think that, there's a lot of folks who probably have strong opinions about this, who are probably biting their tongues on this call, because I know it's been an issue for providers as well, as they've been trying to look to who do we get prior auths from, who do we bill. Like it's still a very big deal. And although, like Leah said, it has reduced, it still definitely exists.
Okay. Yeah, I mean, if you're reporting those to us, I appreciate that, so we can look into those. So.
Okay, Emma.
Yes, sorry about that. I'm trying to multitask, so I am biting my tongue, but I would just have to say we are having countless meetings and discussions about this issue. So it did happen originally when the system came up. It's happened subsequently. We have members. I've had providers actually say to me, "I don't know from one day to the next who to send a prior authorization to, because they're enrolled with one plan 1 month, another plan another month. They go to fee for service." So, and I know we have had many discussions about all of these issues. That's what we have all spent countless hours working on to try to resolve. I agree with what Julie said. I think the problems have slowed down, but for the members that get caught up in this, it's still a huge issue. And we still have many, many members who we still need to resolve from the original errors that have not been resolved yet, which we all know. So.
Yeah, I'll just step in here. It is true. We have identified eligibility issues from the start. This was certainly complicated by unwinding and all the member movement and changes that happened then. There was issues that have been addressed with one really large PRISM release that looked at eligibility issues, additional things. We're committed to continue to work on this. As the issues are identified, we recognize this impacts the member experience, the provider experience, and the team is working on these one at a time or dozens at a time, as they are groupings of work that happen. And it is a body of effort that has been ongoing since PRISM really was launched and these issues cropped up. So we do recognize that there are still issues we are discussing today, right? And that we are in regular meetings on these items. So with regard to the specific items, Jennifer did mention some things that had been worked on and resolved. There continue to be new items and known items that we are working on as a team. In the context of some Stephanie's questions, I don't know, Jennifer, if you had more to discuss in that. But it is certainly something we're continuing to work on and appreciate the impact that it does have on members understanding, at some points, where their enrollment might change, and the challenge that is, and the unfortunate aspect that can be with regard to the changes that may have been caused by the system, and the impact to providers as well. So we're working to address these issues and resolve them, but understand certainly the real challenge of this, and the primary focus, of course, is really how it impacts the care that's received by the individual themselves. So.
All right. Yeah, I think that's where we'd like to spend most of this discussion. So I guess we at least acknowledge there were fixes put in a May release to the system, and that addresses many of the things that were known to be a problem. But for Medicaid enrollees or providers who were hung up in services delivered prior to that or their eligibility, I think we'd like to try and help them figure out how to navigate past issues with maybe balanced billing or something that's going on prospectively, and how they can do that. So Stephanie, if you would like to just take a minute and share some of the experiences that you're aware of that prompted you to bring this up at the end of our last meeting, make sure we're getting everything on the table, and then we can continue to talk through that.
Sure. Thanks, Michael. I'm assuming you meant me, Stephanie, and not Stephanie. Okay, so I appreciate this because this has been an issue that I've heard about from a number of people, and I just want to say a couple of things and then I'll share a story. But I feel like it's so, like, as frustrating as it is for any of us listening, like, so many people that I interact with have absolutely no idea that there's anybody that they can call to like at different agencies or at the hospitals or at the health plan. Like they just don't know. And so I feel like, as much as it's frustrating for all of us, at least we know who to turn to. I think that all the time with my own frustrations. Like, I'm so lucky that I know how to contact the right people, and I just feel like that's such a privilege that like 99.9% of Medicaid beneficiaries do not have. And so I just want to put that out there. So I just like a couple of situations. And I mean, they impact, and I think it's really important that problems like this get dealt with from a systematic way, because they're impacted, the downstream consequences are so significant. Because I know someone who, like, I know multiple people who have just neglected care because they don't understand their benefits and they don't understand what they are eligible for, because they thought that they were not going to experience a bill, and then they experience a bill because of whatever problem is going on with all of this. And so then they're receiving these bills, or they get co-pays at the desk, which is just like a really unfortunate and frustrating experience. Because for a number of people that I talk to, when I try to explain to them like their rights, like that's not something that's known at all, or it's just very rarely known. And so I feel like I'm also trying to explain to them, like, you don't have to pay that $35 or that $50. Like, why don't you like let's try to figure out like if there's been some kind of issue with like not having your Medicaid information updated. And so they're paying out, and they are very, 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 like, there's no discretionary pot of money. And, they don't have a family member to bail them out if things get really tight. So I feel like people are spending money they don't have. And so then they're making decisions about what kind of healthcare they access in a way that would just make everybody want to hit their head on the wall or cry, because it's just really sad what I've heard. I mean, I've heard some really sad situations, and I'm either trying to contact people myself, or I'm telling them the numbers of people they can contact, or I'm telling them to like take their Medicaid card with them next time, or call and get their Medicaid card put on file. But it's like, it is very difficult to it's just very frustrating, because the other thing, even if it gets resolved, I know someone that even if it gets resolved, they're just second guessing every time now that they need to go to the doctor. And these are not people that it's like not a situation where I'm like, okay, you don't really need to go to the ER for that. Like that, I'm talking about like people that should get a mammogram, need to get their colonoscopy, need to get some of these things done, and they just are like, I don't know, I don't really trust that I'm not going to get screwed over again. And so I do feel like that's very probably frustrating for all of us to hear. And obviously, whatever frustration we have about that, like if somebody ends up with cancer that could have been dealt with, but it wasn't, that's like devastating for them and their families. And so it's just a very difficult thing. I know for myself, like, you know, like I don't know, I just say whatever. Like I pay, I don't know, I think 250 something or 280 something dollars a month for my Medicaid. And so like when I'm getting billed, like, and again, I just have a brother that will just straight up tell me don't pay. But like a lot of people don't have that and they don't know what to do when they are getting billed. And then you get spammed with freaking, oh my gosh, credit collector, all of the like bill collectors. And then your stuff gets sent over and then your brother has to go and look at your credit score. Like it's just such a pain. It's so frustrating. It is so like, people don't have time. Like we are taxing their time, we are taxing their finances, we're taxing their trust, which is not something that like there is no trust rebate, you know, like there's no like, okay, like if you overpay taxes, like you get like the refund or whatever, like there is no refund or rebate with trust. You like earning that back is such a harder thing. So like the more that we can do to keep that trust, the better, because it's just like, it's just, anyways, I mean, I've had at least 8 examples given to me in the last 12 months. And I just think that that is like, I'm not a provider. I'm not a person out there. Like I don't work at Holy Cross Ministries or UHEP. Like I'm just a person. My neighbors just like tell me stuff, you know? So I just think that's like that's very frustrating. And that's different people, like not like different bills. If it was bills, like I don't even know. And if they pay, they don't know how they're going to get refunded if they pay. And that's very hard. And I'm sure it's hard for all of you to decide who pays them back if they pay to copay. So I just think it's a problem that like is so much better solved up front. And like you all might see some of the negative impacts, but like the negative impacts of like having to convince somebody that they should actually go to the doctor, that they should trust their therapist, that they should like that it's worthy to invest, like that they're worthy enough to be invested in, and they need to take care of their health, is like something that takes like way like I don't even know the roadmap for that. So I just think it's a very important problem, and I appreciate the attention to it. And all of you that have been helpful, I still don't really fully understand exactly what's going on, but I appreciate all of the many people that I've like reached out to about this. But it really needs to like, it needs to be dealt with like upstream, because it's just like, it just, the trust thing is so real. That's just the common like that's just the common factor I'm seeing in the outcomes of everybody that it happens to. And or somebody that paid their bill instead of paying their rent. So that was also unfortunate. So anyway, it's really, really important that we get these things dealt with. So thank you for the work, and hopefully it can get fixed
Thank
quickly.
you, Stephanie. Do you have, so in addition to like fixing the system, which of course we're all interested in having happen, do you have any specific suggestions of things that would be helpful for the department to do in terms of trying to communicate to Medicaid enrollees what the issue is and what they should do if they do have a problem? Do you think some type of a mailing or something through the EREP email system would be helpful, or does that cause more confusion to the members if they get some type of communication? I think just like you're saying, the knowledge of how to navigate the system and have peace of mind of knowing that they don't have to pay on some of these bills, but in some cases they might actually be legitimate bills and not, you know, anyway, just where they're being balance billed, and that's not appropriate. Any thoughts you have on that?
So I feel like I appreciate the question, Brian. I know we talked about this at one point. I don't remember where we landed. And I have a different notebook that I'm taking notes in today than the one that I had in that meeting. So I don't remember exactly where we landed, but I had said like, I feel like, I mean, there's just always a need for like a patient know your rights, like a beneficiary know your rights thing. And I think that's just like, this is one of many of the things that I think would be one of the most important. Like if you chose the 10 most important things for members to know, this is like, in my opinion, in the top 10. I feel like I don't know that I would say EREPs. Like I think maybe like a postcard or a mailing in the mail of just like, you know, like something that just kind of like again, I feel like Brian, where we got stuck is like how we phrase it, because there are sometimes there are co-pays for sure. And again, I do think but I think it's like the distance between like a typical copay and a copay in like other scenarios is like, it's just like a very big difference. And so I feel like that is also where it's like, if there was a way to just like explain, like if you're paying copays larger than this, or like if you feel like, I don't know how we'd phrase it, and we can maybe have another conversation about it, but I do think something that was just like, this is not, you should not be, or I mean, just something that acknowledged like we've had some technical glitches and we worry that like some of you may be, I don't know what you guys can say, but like if you're just upfront and say like, and encourage them to call HPR or Tracy or, their health plan. It's a tough one because again, like it's such a complicated system that like, I mean, I still know people that don't understand what the health plans are, and they don't know the difference between DWS and Medicaid. So there's just so many differences people have to keep up with. I have a hard time knowing like what's the best solution, but if it was something where HPRs were like going to be the point person for this, then maybe just having people contact HPRs if they feel like they've received any like what's the word, like any like billing that's like raised questions to them, like any, I feel like they're the word that I'm looking for, but any, oh my gosh, there's like a word, any just, well, that's not really what members call it, so I mean that's what maybe we call it, but I guess it would be more like just any unusual billing, like if they received unusual bills or bills that were not like their typical, low, like if they feel like, if it feels like you're having to like contribute a lot out of your pocket, like let's double check that, and maybe having HPRs. I don't know, it's just something where it's like, yeah, you might have some people call that don't like, that do have to pay those bills, but we would rather that be the case than people paying stuff they don't need to pay and like really should not be paying. I've just been telling everybody not to pay, and because that's just, until I was like, let's just cross that bridge later. But I'm like, right now, I just tell them not to pay because they get these really scary notices with red ink and text messages and phone calls. And so I'm just like, let's not pay. Let's figure this out. But I don't know that they hear that from everyone. So anyways, I think maybe something that just said like unusual billing or higher than usual copay or bill or something that's maybe a little bit, yeah, I don't know that they know what balance billing is. So
Okay. And Jennifer Meyer-Smart has put in the chat the phone number and an email address to get in touch with the HPRs. If people have questions, that would be a good resource for us to refer people to. And then I see Jen and Andrew have their hands raised. So Jen, let's go to you and then Andrew.
Yeah, thank you. This is a response specifically to the balanced billing comment, knowing that's not allowed in the Medicaid program, right? But again, members may not know that or even understand when they get a bill what to do with that. We've discussed this at length with Stephanie, Brian, and others on the team. We've worked with our PR folks to do kind of a two-pronged approach on this, and are working on notices, materials, communications. One is going to go to providers. There's a video link that has been put together, like a video tool, provider education piece on this that has already been designed. It was meant to be packaged with a MIB and communications that would be pushed to providers, educating them around the balanced billing aspect with Medicaid and their requirements on this. Additionally, there have been designs on the member communication side as well. So what this is meaning for members is, right now we know, for example, that it is in the member manual, but I think we've discussed it's not very prominent. So it might be, it's several pages in rather than being closer to the front, and doing other things like maybe doing social media pushes and other ideas that we have that we're working on in upcoming months to be released both to providers and members. So this isn't work I don't think we've brought here before to this group to let you know we're working on this, but it has been done in collaboration with the concerns that Stephanie has brought with us, and we've been sharing and brainstorming ideas, as Stephanie had mentioned, about how to reach members, how to get the message out to members, but also to providers who are actually, their offices are doing this activity, right? And to really help educate from that angle as well. So I don't know if there's anything else to add to that, Brian, but I can say I know that we're working on these pieces, and in the upcoming months, we should have these ready for distribution as part of our regular notice cycle, and then also separately for member outreach.
Okay, thank you for that comment. And I guess from the perspective of providers, it doesn't look like the providers are balance billing because of the information they've been sent by Medicaid, and the individual is not showing as being enrolled necessarily in a managed care plan or even showing up as being eligible in some of the cases that I've been made aware of. So I think as you approach your communications with the provider community, rather than just a broad perspective, maybe not necessarily accusation, but an approach of, hey, we've seen an increase in balance billing, I think it also needs to be coupled with an awareness that because of system issues, a lot of the reality of enrollment in managed care plan or enrollment in the Medicaid program in general is not coming through accurately. So we realize you may be seeing things that leave you with the impression the individual's not enrolled in Medicaid or a managed care plan. Here are resources for you to maybe check before you send out a balance bill to the Medicaid individual, likely, if they've been enrolled in Medicaid recently or something to that effect, might also offer a little perspective just from the provider standpoint. Okay, Andrew.
Virtually the only contact I've had with my home health agency in the last 6 to 9 months, because they're not able to provide any staff to me, is at the beginning of almost every month when it hits the second, and they say, hey, they call me up and say, hey, it doesn't look like you're enrolled in managed care anymore, and you've been transferred to fee for service. Can you fix that? And so, and the phone call comes at least 2 or 3 days before the letter comes that outlines the plans that I'm enrolled in for the various different components, ACO, pharmacy, mental health, and all of that stuff. And so I have ended up calling constituent services every month, and Tracy has gotten to know me very well, and says and has flagged it now so that she takes care of it for me every month, because she knows it's coming. So this, the Steph's point about communicating, how to communicate this is very important, because individuals will likely get contacted by their providers and say, hey, this is an issue, do something to fix it, before any snail mail arrives from the department saying this is what your setup is for the month. So we do have to figure out how to make sure that members have the information that they need in a timely fashion, and not to overwhelm Tracy, but constituent services is is another option for folks to contact if they need to as well.
Okay, great. Thank you. Those are some good points. I think just in terms of communication and resources for people as they're trying to help individuals navigate this. Just looking through the chat, Gina Tuttle, you brought up an issue about challenges for the health departments getting access to PRISM. And I know the health departments frequently act as a contractor in lieu of like an HPR. I'm just wondering if that's what you're speaking to. Like the local health departments will frequently help people find providers in their communities, and if that's a challenge or something you'd like to just kind of speak to a little bit more.
Hi guys. Yeah, so we do a lot of help here at the health department in helping people get on Medicaid and letting them know about the services, their rights, etc., referrals. But one of the things I was trying to work on today is I work in the check program, and I was working my check program. I couldn't even pull up a name. Even with their ID number and their name, it wouldn't pull them up. And I can't do my work, you know? And so I contact people at the state and they can't help me. And this has been going on for a year now. And sometimes this process works and sometimes it doesn't. But no one trained me how to use PRISM. I had to work on it myself. I had to call another nursing director from another, health department, and she got on a conference call and showed me how to work the system. And I know very little. I mean, I know enough to get around, but it's been super frustrating.
Okay, so I guess as we're trying to steer people to the HPRs and in many cases the local health departments to help resolve some of these issues, any comments from the department on making sure the local health departments have the resources they need as they're interacting with Medicaid enrollees in the more rural counties of the state?
Yeah, Gina, thank you for making me aware. I will follow up with our contact and see what the issue is. We will address that.
Great. Okay, we're running a little behind on our time. Let me just ask if there are any other comments on this, as we just want to bring this to a close. So I think the ask is some type of communication to the Medicaid enrollees about some of the experiences they might be having if they experience balanced billing or challenges with their enrollment, cancellation of appointments because of provider confusion, resources where they can go to try and help navigate some of these experiences. And I guess, do we think the HPRs are going to be in a position if Medicaid enrollees have been balanced, billed inappropriately, made a payment, and help them work through getting that payment back to them if that's in the scope of their responsibilities? I guess just making sure we're not directing people to Medicaid staff and them not being prepared or in a position to feel like they're able to navigate those challenges or intervene on those issues. But any other requests for the department other than what I've tried to summarize there?
And I think to your point, Michael, I think it would be good if we got back to you about particularly around billing issues, because the degree to which HPRs are going to be in a position to help resolve that, I think we need to just take that back and discuss the best pathways.
What that's going to look like.
Dealing with those. Yeah.
Okay.
Okay.
Okay. Well, thank you for the presentation, Greg and Jennifer Meyer-Smart, and Jen for jumping in and offering some additional perspective. Definitely recognize there are a lot of challenges in administering such a complex program, but as it impacts the lives of those who are enrolled and causing confusion, inability to access their care, having appointments canceled and being billed for services they shouldn't be billed for, I think we all have a common interest in raising visibility to how they can help navigate that and get a resolution. And thank you, Stephanie, for bringing this up so that we can try and help the enrollees navigate this. Okay, we now need to go back on the agenda since Jen has joined us, and we'll give you, I think we have about 10 minutes of your 15 allotted to still go through if you want to make your presentation on updated or upcoming policy changes.
Sure. Thank you, Michael. And thank you for the time. I'll try to be fairly quick, at least on the two top items that I'd like to share with you, just a couple policy updates, and then spend a little bit more time on our justice work. I wanted to update the committee that in the last round of grant opportunities where a CCBHC or a certified community behavioral health clinic grant opportunity was available, we had been asked by some stakeholders and legislators actually to consider applying for that. We did. And on the last cycle of funding that was released, we were not approved for that grant, but another notice of funding opportunity was released in the past few weeks, alerting us to an opportunity to apply for this $1 million planning grant. And so first, I'd just like to say, in the context of time, CCBHCs, we have several providers here in our state that are enrolled as designated CCBHC providers. And these are like integrated models of care, really, that provide comprehensive behavioral health services and coordination for the physical health components. These have quality measures built in, and this is a model that many states across the country have used, and some of our providers here in our state that are delivering services to Medicaid members are also CCBHC enrolled provider. So I wanted to just alert the committee about this notice of funding opportunity. The grant application is due on September 12th, which is just now a few weeks away. And we've been asked to reapply for that and seek what that planning grant opportunity would be. So we have our team working on that, and just wanted to let the committee know that that is an area we are looking at. Next item I wanted to update is something we brought to you many months ago now, is about a refresh of our EPSDT policy. And at the time that we presented it, I wanted to let you know, first of all, that the Utah Medicaid program is compliant with all standards that are put in place by the federal government, and our policy does meet all the necessary elements for the EPSDT program. The EPSDT, again, is early periodic screening, diagnosis and treatment program that is eligible for individuals who are under 21 years of age. And what this program does is while our Medicaid members who are under 21 years of age are eligible for a Medicaid benefit, EPSDT is a bit of a benefit that may go beyond the traditional Medicaid benefit by allowing people to get access to medically necessary services. What I wanted to share is that the team, as I had mentioned earlier, was working on a refresh of this policy to create greater visibility on behalf of both members and providers about what this EPSDT program is and how they could access it. So the first step in this policy refresh is, first of all, creating an update to our EPSDT manual. This was a manual that had been in existence in the past. It was retired, and we've done a rework of this manual in an effort to create greater visibility for providers and an understanding also for members. It's also included in our statewide provider training that is now occurring now. Our manual will be released in September, and then we have additional plans to develop a website that will also serve as a tool for both members and providers so that they understand what EPSDT is and how to access a request for services that may meet that those requirements of being medically necessary. We've also streamlined our processes on the back end so that when a provider does request a service that is covered underneath the EPSDT benefit, that we have a streamlined review with our medical director so that the individual can receive those services timely once that review happens. And of course, that's on the fee-for-service side, but we are also working with our managed care partners as well to make sure we're in line with each other. So wanted to update you on that work. Again, this is not a policy change. We've been compliant across our Medicaid programs and our operations with the EPSDT requirements. This is the ability to have just greater transparency and visibility for members and providers about that benefit. The last update I just wanted to share was the ongoing work we are doing for our Justice Reentry Initiative work. Again, this was an 1115 waiver that had been submitted in 2020, but was recently approved by CMS in July of this year. Following our approval, we do have a timeline of events that we do want to share with you so you can understand what we are doing. Many times after a waiver is approved, we go ahead and start, put that service in place or start getting the program that would support that waiver approval in action. What we know now is that the implementation phase will actually really be put in place over many months, and we do not anticipate any jail or prison coming online with the justice waiver before mid-2025. One of the things we'd like to share with you today is just to understand, following the approval of the waiver, what's next? What are you working on? And I think this timeline has several different milestones on it, but wanted to just call out 2 mandated CMS milestones that our team is working on. If you look at the far left on July, where it says we did receive the approval for our 1115 justice waiver, our next deadline that we're looking at is a November 1st deadline for what's called an implementation plan. This implementation plan is about a 10,000 foot view of our operations today and our policy and the work, the body of work that is part of our justice work. And what this implementation plan is it looks at our as-is process and then what the to-be process will look like. So it gives us an opportunity to define that for CMS. This is what we have in place today. This is what we hope we are planning for as part of our implementation and our go live pieces as laid out in this plan. Our team is actively working on the implementation plan now. We hope to have it completed by the end of August so that we can then begin sharing pieces of that plan with applicable stakeholders so they can also see what this plan looks like and contribute to some of what we will be submitting to CMS. We can have review and stakeholder input on pieces of the implementation plan. So we would look to do this through September and maybe have that wrapped up by early October and then get that submitted to CMS. The other milestone I mentioned that's necessary for CMS is what's called a reinvestment plan. And one of the pieces of the justice waiver that we've shared with you in the past is the federal dollars that will be now offsetting the state and county dollars that are now currently supporting these services for Medicaid members within the carceral setting. Must be reinvested into services and programs that support this population. And as a result, what we have to do with CMS is submit a plan to them called our reinvestment plan on how we will reinvest the federal dollars, what are the federal dollars and that state and county offset, how we'll reinvest these dollars into services that will support this population. So the deadline on this for us to have this submitted to CMS is on January 1st of 2025. So as we are working on our implementation plan and engaging stakeholders in this work in the upcoming weeks and months, we will also be engaging stakeholders and our working group members on that reinvestment plan as well. Now, if you would look along the bottom of this slide, you see that down arrow, for that purple down arrow. One of the things we are doing in the next few weeks is kicking off a stakeholder work group. And this was going to be more focused on executive level leadership positions across a variety of areas, our behavioral health system, our state and county officials that want to be involved, legislative officials, certainly our leadership positions within our jails and Department of Corrections as well, to be able to have input on our overall goals, vision of the program, and some of the milestones we'd like to accomplish. To complement the work of the stakeholder work group, we know that we need an implementation teams that really will be crafting the necessary elements to really define how this will work. And so we have implementation teams that will be more in the weeds, and we'll be developing a template of what this will look like for our state and really defining more of the operational and the process driven metrics that we want to look at. So we have our stakeholder work groups that we'd like to kick off in September, and that these will be higher level positions, and then we'll also be inviting others to participate in an implementation team as well. So for the sake of time, Michael, I want to wrap it up, but wanted to let you know we'll be revisiting this numerous times over the next, every meeting. Really, we could really touch on the work and give you a progress update on this, but certainly wanted to share with you today where we are with that and where we are with our planning and our work and engaging stakeholders in that. And yes, we have introduced this through the Indian Health Advisory Board, and will continue bringing that to them and inviting them to these meetings and participate in these the working groups as well as the implementation teams as well. They are part of that stakeholder work group.
Great. Okay, thank you again. Appreciate those updates. All right, final item on our agenda. Unless anybody has any urgent committee member updates they want to bring up before we get to our final agenda item. You've already spent all your time, Greg. You don't have any left.
I just wanted to note for the group that I did put that constituent services would be the best contact related to member billing issues. And if you look in the chat notes, you'll see both the number to contact constituent services as well as an email address. So I just wanted to note that for the group.
Thank you for highlighting that for everyone. So again, those resources for people. Okay, final item on our agenda, as I mentioned earlier in the meeting, this is the last meeting that the current executive committee will be running. So starting next month, we will have Rachel Craig will be our new chair, and Dr. Jennifer Brenton will be our new vice chair. And first of all, even though we don't have a vote this time for people to choose between two candidates necessarily, I think it would be helpful for the MAC members to vote, at least to give support to the new MAC committee member, the executive committee, just to show our support to you and your upcoming leadership role, and that you have the support of the MAC. So if those of you who are on the MAC, this time we won't do it by silence, which is how we do our vote for the meeting minutes, which is usually easier. I think we would just like to extend our support to you. And if we could all go off of mute and just vote aye in favor of our new executive committee members. All in favor? Aye.
Aye. Aye.
Aye.
Great. Thanks so much. I would like to extend my thanks to Jennifer Marchant and to Joey Haney for their service on the executive committee with me. We appreciate all of the support from the committee members over the last 2 years on many of the topics that we've addressed and tried to raise visibility to and help just do the best we can. So thank you for all your kind messages there.
Yep. Thank you, Michael.
Thanks, Michael.
Thank you.
Thank you, Michael.
Yeah.
Thank you.
Thank you, Michael. Can I say something really fast? I know we're
Yes.
out of time, but I have 30 seconds. I did want to just thank you. I I feel like I am sometimes I know we don't always see eye to eye on every single thing, but I really appreciate the things that you have done to make sure that members on the MAC, like consumers on the MAC and consumers on Medicaid are that we do have a say on a number of things. So I do really appreciate that and appreciate your willingness to do that. And I also want to say I appreciate the new executive committee and also just recognizing that like a consumer representative is not currently represented amongst them as far as I know. And I just want to say that I do think it's really important to continue to strengthen the opportunity for consumers to be able to have a say. And I look forward to hearing how we're going to do that with the beneficiary advisory committee. And it's just, I think it's really, really important. We all have different perspectives, but there is a unique perspective to those going through it. So appreciate the way you were able to, you and Joey and Jennifer were able to have our voice heard, and just hope that we can find ways to make sure that that's not lost. And appreciate and trust that Rachel is going to do a great job as chair, but just wanted to say I do think that a consumer should be, anyway, we need to strengthen consumer representatives so that so we can make sure that they're included in the rotation in the future. Thank you.
Okay, thank you all. Again, thanks everyone for joining our meeting today and all of your support over the last couple of years. And we'll just go ahead and adjourn since we're at time. Thank you.
Thanks, everyone.
Thanks again, Michael.